talk in next 15-20 minutes only because we don't want to waste more time. Already we are delayed. But after a very very lucid talk from Dr. Warren Lee, and that was also on a topic which is very not normally talked in our type 1 meeting. So we all enjoyed, Warren, your talk, and we could have some questions, but I'll be talking something which is very basic, and that's a major problem in our country because still we are not able to take care of them for a better care for at least diabetes. So we are not doing actually celiac screening for many of our patients. But today we learned some of the clinical things which we should do in our diabetic patient. So what I'll be talking in 20 minutes, the type 1 diabetes in our country. I don't have any conflict for this for this particular talk. This is 2019 IDF data, which shows that Southeast Asia, if you see here, it is almost like 1,84,000 or 1,01,000 patients of type 1 diabetes. In India, between 0 to 14, it is 95.6 thousand. So after the North America, India is the country, particularly from after the USA, we may have second highest number of type 1 diabetic patients in our country. Even our incidence and prevalence is much less in compared to North America or the North Europe, but still the number of patients, because of the country is big enough where we have more number of patients of type 1, and still the care for these patients is not to the mark. There are multiple papers which is published from our country which shows that the different population had shown different number of patients, that it could be the range between like 10.2 cases per 1 lakh. That is from Karnal data. The Karnataka in Chennai is talking about 3.2 and 17.193 this. So in currently there are around 130,000 children, which is what we are assuming, but still the incidence of type 1 in our country is rising by 3 to 5% per year. When we are talking of type 1 diabetes, I think we can't talk without showing this picture that before 100 years exactly, we were having the insulin, and the first child who was given the insulin is Thompson, and you can see within 2 months, this child is improved like anything. So you know that insulin is life-saving, not only life-saving, the patient who is suffering from this, all his suffering goes away immediately after starting the patients on insulin. But even after 90 years of insulin therapy, this is one of the paper which was talking about that Cara Newman case, which is an incident in which parent of a sick child refused to treat her with anything other than prayer, and resulting in this child death. And this had come, but this is very common. Still after 100 years of insulin discovery, still we find that in our country, we see our type 1 diabetic patients, they are dying just because they are delayed for the diagnosis. They are not given insulin, and still they go on alternative therapy. And sometimes these alternative therapy people also talk that they can cure type 1 diabetes. So this is something which is very shocking. It's such a big country and we have so many type 1 children. Every year we get so many new patients, but still these are the cases which we get, but they all are underreported or not reported in our country. We all know about the type 1 diabetes, about the DCCT trial. I think after DCCT, we could understand that it's a tighter the glycemic control, lesser the complication. But at the same time, to get a tighter control, to get a very tight control, we are paying a lot of price, and that's what is hypoglycemia. It is the severe hypoglycemia. One side, you are going to have the less complication, but as you want to achieve the tighter glycemic control, like this is what we want to have, but at the same time, the rate of severe hypoglycemia per 100 patients a year will be roughly around 60. So that's very, very high. And that's one of the reasons why our patients are not able to achieve tighter glycemic control. Even in DCCT trial, when they were aimed to achieve tighter glycemic control less than 7, average or median A1C they could have is around 7.6. The glycemic target in type 1 diabetic patient is less than 7 as per American Diabetic Association, or even if you can achieve less than 6.5, nothing like that, because less hypoglycemia is very important. And some of our patients who are on pump therapy, who are on continuous glucose monitoring, we are achieving less than 6.5, but even less than 8 with the patients who have hypoglycemia unawareness, or elderly patient with limited life expectancy or the advanced complication, we may achieve 8. But the diabetes care in India, which had shown that type 1 diabetes average A1C in our country is around 8.5 to 9. We have some of our centers who are part of sweet registry. We have some centers who are part of CDIC data. So where we had shown that our patients average A1C, these are the patients who are given glucose meter, who are on the strips, who are on regular monitoring, who are coming to the doctor regularly. They are seen free of charge. Still their A1C is around 8.5 to 9. So this is something which we should know, that those patients who are coming to these centers, who are already center of excellence, but still their patients A1C also average is more than 8. We know that type 1 diabetes management, it's a 24/7. It's just not the insulin or medication. It's a constant juggling between the insulin and food intakes. I mean, balancing between a physical activity and a diet along with the insulin. And every time patient has to monitor 24/7, that's really something which is to be done, a constant juggling which is required. Now, 7-point self-monitoring of blood glucose. I just wanted to know from all the experts who are here on the panel, and many of them must be listening, that how many of our patients actually doing 7 points in a day. We don't get any patient who is doing even 7 points. Even during my clinical trial of some of patients of rapid acting insulin, which we have done in last 10 years for a type 1 diabetic patients, even they were not ready to do the 7-point SMBG very regularly. So I normally tell my patient every day minimum 2 sugar report. That's minimum. But weekends, at least once in a week, in a Saturday or Sunday, or if 2 times, they should do even 7 points also. That is before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner, and then midnight or even evening time also. And through that, we used to get a graph. We used to know in last 7 days, multiple points I used to put, and then we used to get a graph. But that typical type of graph you can get when you get a continuous glucose monitoring for the patient, which we were getting with the Medtronic continuous glucose monitoring. The multiple doses used to come, and with the advent of ambulatory glucose profile graph, which is a software which has been first used with the Libre Pro, and then it had come with the Libre, and now it is also available with Medtronic. It gives you much a convenient way of understanding the glycemic variability in type 1 diabetic patients. If patient is doing a continuous glucose monitoring, you can get a ambulatory glucose profile graph. But even if patient is not doing that and is doing multiple times self-monitoring of blood glucose, please try to get a graph for the patients to know that how patient sugar is actually vary in the day or in the post-meal time or even pre-meal time. How this continuous glucose monitoring helps the patient. I mean, this is very important for the doctors, for the clinician, because in DCCT trial, I had shown you the patient to achieve a tighter glycemic control, we have to almost 60% of the patients, they were getting severe hypoglycemia. But the patients who were on a continuous glucose monitoring, this is a JDRF CGM data, which had talked that the patient who are put on continuous glucose monitoring in 2008, which is almost 25 years of DCCT, they could achieve their A1C from the baseline of 7.6 to 7.1, and the risk of hypo had come down from 62 to 20. So that's very significant. Low, very, very significantly low. And that is the reason we must talk to our patient if we can have a continuous glucose monitoring. If not continuous glucose monitoring, at least 7-point time, a different time self-monitoring of blood glucose, you can reduce significantly hypoglycemia risk, and at the same time, you can achieve a better glycemic control for your patient, which is averagely they are at 8.5 to 9 in our country. These are the insulin delivery device, which is approved from American Diabetic Association. This has been published in Diabetes Care 2020. I just wanted to tell the insulin syringe, which still many of our patients who are with the CDIC or Life for Child, these are the patients who are given free insulin syringe. Actually, the evidence is now C. So they should not be given. Ideally, it should be on pen. They should be on multiple daily insulin injection pen, or they should be on pump. This is what the standard of care all over the world, and that is what American Diabetic Association is also talking, that our patient should be either on multiple daily insulin injection with the help of pen or with the pump. While in India, still we have more than 50-60% of our patients are on insulin syringe. So how long some child has to continue the insulin syringe? If you just see, a child has to take minimum 1460 shots in a year to stay alive. I mean, these many times a patient has to take the injection. This is a picture which was put on a social media by mother of this child, and she just wanted to convey the message that how a type 1 diabetic patient has to survive with these many shots in a year. Even she is not on the insulin syringe because she might be on the pump. You can see here the right side, there is a pump, and she is also on continuous glucose monitoring. But they had shown that yes, a child has to take these many shots just to increase the awareness about it. Even this child is not taking because there is also the cap on the syringe too. The demographic data from the German paper, this has been Thomas paper, which had talked that those patients who are taking more than 6 injections in a day, it means more bolus, number of bolus are more. These patients, they are achieving better A1C control in compared to the patients who are on 2 to 4. Now, most of Indian patients, either they are on NPH and R, which is 3 injections in a day, and some of them are on glargine with rapid-acting insulin analog. They might be on 4 shots in a day, and this you can see the average A1C. And this is really true in our country. But those patients who are on pump or those who can afford to have more than 5 or 6 times short acting any times when they are eating or correction dose or any snacks, when they are taking more than 5-6 shots, their A1C is much better in compared to the patients who are taking 2-3. So there is no point of now less than 2 or premix insulin, which is still popular. I really get surprised when I see someone is taking premix insulin, and many pediatricians, many primary care physicians, and even some of the diabetes and endo are also writing still premix insulin, which is only a insulin for convenience, not for the control, just for giving the injection to keep patient alive. So there is a role of continuous subcutaneous insulin infusion pump. We have less number of patients, but still in India, we have around 10,000 patients who are on insulin pump. Out of them, 5,000 patients are on type 1 diabetic patients, and these 5,000 patients not on sensor augmented, but still we have good number of patients across the country. I have also personally more than 200 patients who are on insulin pump. What's the advantage of insulin pump? Many people think that it is only giving an example because you can have different basal rate. You can put different basal rate, which is very important, because when you are putting the patients on a long-acting insulin injection, you are just giving 1 shot, and then for 24 hours, there will be only the same amount of insulin will be getting absorbed. While when you put the patient on insulin pump, midnight or afternoon, evening time, and patient is playing, person is playing at that time, you can reduce the dose of basal, and that advantage come only with insulin infusion pump. But the second more very important advantage is there with the pump, a child can take, or even a type 1, any child 1 or adolescent, they can take multiple short-acting insulin shots. And that is more possible only if someone is on pump. So every 3 hours, 2 hours, whenever they are monitoring or when they are on continuous glucose monitoring, they can take the correction dose of as and when they are taking snacking, which is normally 6 times in a day is very common in our country, where they can take an extra shot of injection. And that is one of the biggest advantages of pump over the multiple daily insulin injection. Now, if you see the same paper from the Germany from Dr. Thomas, then which he has talked that before 2000, I mean, there were few patients who were on premix insulin, I mean, less than 2 shots in a day. This is the data from Germany, while after 2000, there is hardly any patient who is on a premix insulin. But up to 2015, you can see, even before that, from 1995, always more than 50% of the time, 50% of the patients were on 4 to 6 injections per day. This is what it is commonly used since last almost 30 years, 1995, the data is showing. And now the patients are on insulin pump, more than 50-60%, and now probably 75% of the patients in children in Germany, they are on insulin pump. We have one of our paper which we have talked about the practical issues about the insulin pump. As I told you, one of the biggest problem other than cost is an education. Education of patients, education of caregiver, education of pediatrician, education of primary care physician, and education for every one of us. Unless we educate our healthcare provider, we can't have more patients on insulin pump. There are multiple papers which were published in our country also regarding the use of insulin pump in our country. We are moving from insulin pump to the artificial pancreas. At this point of time, we don't have, but yes, there are few patients even in our country also who join the artificial pancreas system, do it yourself, or they are doing DIY or a looping, which is a club internationally they are doing, and they are not waiting for any company to come out, they are doing on their own also. Now, let me talk after all these advancement and whatever we have. Despite a lot of advancement, there are many barriers for the healthy life with type 1 diabetes because of lack of awareness. That is at the level of community. The community does not know that type 1 is so prevalent. I mean, these children are dying. There is a problem at the level of community, also the culture. People don't want to talk about the type 1. Even the parents, the caregiver, the child, or the even young adult who does not want to talk about that they are type 1 diabetic patient. There is a social taboo for that. Even the child who does not have the, or the family, they don't have the resources to have the insulin properly. The family have the issues with that. And even when the our associations, like some of our foundations who are giving them insulin, for them, these patients have a, the clinics are quite far away and they can't afford to come there to regularly. Even some of our government hospitals are also providing free insulin, and the healthcare professional, that is the one who is practicing in that particular village or in that particular district, who have a very poor understanding of childhood diabetes. And this is one of the most important reasons why our children are not actually getting a optimal care. And I think this is the thing which we have to improve. And I will be talking in next couple of slides what we are doing from RSSDI. So we need a holistic support. We need an infrastructure. We need healthcare professional training and education. That is what we have done. A type 1 diabetes network across the country. Some of the patients who can't afford, we are going to give them, and we are already started giving them free insulin and supply. We started doing an education program, patient education across the country with the help of some of the industry partner and with the CDIC, Life for Child, and through RSSDI, Diabetes India. We are having our own diabetic registry. We are also the part of international registry like SWEET registry. We have ICMR, a young diabetes registry, and a lot of learnings and outcomes are coming because of this holistic support program which we have for our country. But still, after 100 years of insulin discovery, we are struggling for financial constraint in many of our children with diabetes. We don't have our patients who are coming very regularly to our clinic, even those endocrinologists, diabetologists, or dedicated pediatric diabetic clinic. They don't get the patients on a regular follow-up. Even they are seen free of charge, still the clinical attendance is very poor. The improved A1C is not there. Average A1C, which I already talked to you, is around 8.5 to 9.5. The patient satisfaction and education is poor. Even our doctor education and satisfaction for that is also poor, because the primary healthcare physician or pediatrician or some of the physicians, they just don't want to learn more about type 1 diabetic patient, but at the same time, they don't want to leave this patient. Once the patient come to that, they start writing the treatment. That's my problem. If I feel that it's not my cup of tea, at least you leave it, you send to the person who can treat these patients in a better way. Improving the psychosocial outcome is also very poor. And that's how we have come out with a RSSDI type 1 diabetes network across the country, a mission to build a positive ecosystem for our type 1 diabetes patient care, pan-India to the last mile. The vision of this to empower doctors, educators, and patients with knowledge and awareness in a structured and scientific way across the country through RSSDI. We have to enable a child with diabetes to be a member of productive workforce of the society. Type 1 management is just not the insulin. It is just not the insulin. It is much more the insulin than education, education, and education. There are multiple myths which are there in our country for type 1 diabetes. I'm not going detail about all these things, but these are the myths which are there, in many of our type 1 diabetic patients, their relatives, their caregivers, and even some of the doctors also have that feeling. And one of the very important, the type 1 will result in complication and death in near future, even whatever we do. And this is one of the very important myth which we have with many of our doctors who are even practicing diabetes also. This type 1 diabetes network program, which we are doing it for our district educated doctors, but at the same time, we also have come out with a center of excellence across the country. We have, these are the doctors who are training the doctors, they are training the educators, and we are trying to make more educators and giving them a certification with the RSSDI and trying to get employment in diabetes clinic so they can work as a educator, those who are caregiver or those who are type 1 diabetic patients or those someone who is really interested in type 1 diabetic patient. This training is done primarily by these center of excellence, which we have almost 40 centers which are identified. With each center, there are 4 and 5 centers who are there, who are associated with these centers, and they are the one who are training these doctors, educators, even in medical schools, as well as in the private setups also. We have modules which are being created already, and they will be there within short period of time on our website for healthcare professionals, for educators, for coaches, and for patients also. So the best case scenario, what we are looking for, a correct diagnosis, and education for self-management, a peer support, a psychological support, and access to a specialist, and access to knowledge of technology. So this is what we are looking for, that a type 1 diabetic patient should have the right diagnosis and a right treatment, and the best specialist opinion also it should be there. So the key factors which we are going to monitor for these in centers and type 1 diabetes network: the reduction in the number of children developing diabetic ketoacidosis, decrease in mortality, reduction in the number and duration of admission in hospitals, reduction in the number of school days lost, and a growth of child to their adequate growth potential, and significant increase in body weight of children with type 1 diabetes. My dream as a president to empower doctors to the last mile through type 1 diabetes network program or diabetes technology network, to reach out in a rural area, free insulin who are needy through RSSDI, young leaders from RSSDI, multiple NGOs which can be the partner with us, and some policy changes in some government, and to have an affordable technology in our country to treat type 1 diabetes. We know that few statistics in type 1 diabetes we can't ignore, and we can't have anything, but our role began as a healthcare professional, and it continues as a friend. We are like a coach who supports the children to live a healthy life. So it's a child who has to play, but the doctors, we have to be like a coach for these children. To conclude my talk, treating type 1 diabetes is a challenging task in India due to vast difference in socio-economic status of the patient, educational background, and availability of diabetes care. There is a distinct need for comprehensive diabetes care program, which must be more wide-ranging. Essential diabetes care should be universally accessible in terms of technology, expertise to general population, and acceptable to them at an affordable cost. Insulin must be made available and accessible to every type 1 diabetic patients in India, and there should be much more such program which can address type 1 diabetic patients either through government initiative or through public-private partnership initiative. With this, I thank you very much.